On today's episode of Gross Anatomy, Lauren and I dissect the TV show The Pitt, the first 7 episodes. Check it out. Hey everybody, welcome to Gross Anatomy, where we explore the sights, smells, and sounds of medicine, how it relates to movies, TV, books, pop culture, podcasts, and the world around us. And I'm Dr. Jason Cohen.
And I'm Lauren Taylor. We are alive with energy to dissect the show.
Ooh, I like that. We're dissecting The Pitt today. Very gross anatomy and very medical. I love that.
Yes, and I think we should just jump into it because I have so many questions per episode, unless you want to give an update on anything.
No, I don't mind jumping into it. The only thing is I haven't finished the series yet.
What?
I have 1.5 episodes left. We binged it. Believe it or not, we tried to binge finish it last night, and we didn't stop watching till like 12:30, and then I realized, oh my God, I'm a doctor. I have to be up in the morning to take care of people. So finally at 12:30, we stopped halfway through the second to last episode. So we may have to do a part 2 when I finish watching the second episode, the last episode, but I'll leave it up to you.
Okay, I was thinking because we have a lot of questions, it might be a part 2 kind of thing. We'll see.
Could be a part 2, or maybe even a part 3.
Yes, and we've got clips.
I'm ready. You ready? What do you got? Let's do it.
All right. So episode 1, we have a video for this. A surgeon walks in and oversees how the residents are doing. She kind of like takes command of the room, and I'm just wondering if that's real, if that's how you would like enter a room and observe residents.
Could we actually watch the clip? Are we able to see that clip?
We are going to go to the clip.
Let's dissect the clip.
Good Samaritan dude has a small left temporal intraparenchymal bleed. No epidural, no subdural, no midline shift in the brain.
That's good news.
You can recover. CT can take her in 5. Let's have a look. Bandage scissors.
All right. If an artery is totally transected, the smooth muscle in the tunica media contracts with hemostasis.
But if it's a partial cut, get out your umbrella.
Grab a culture from the open fibula before you reduce. You're up.
I'll stabilize the knee for the reduction. Dr. Langdon will be distracting distally before moving medially to clear the tibia. Ready?
My student down.
I'm not going to answer your question yet, but
Okay.
I used to take evil pleasure in having my med students, or even in my pre-med students, I used to take an evil pleasure in them passing out. Like it used to make me so happy when people would pass out. And finally, fairly recently, a couple of years ago, we were in the office seeing a patient, and I was just describing something to the patient, and I had a couple of students off on the side just standing by the sink listening. They were standing listening to me go over like the surgery and what we're going to do in the surgery to a patient. And out of the corner of my eye, I see this one student starting to like shuffle a little bit and like move around funny and get a little twitchy and stuff. And I didn't think anything of it, and it was a little distracting. And then all of a sudden I look over, and that student, all of a sudden just started going, and I wish, and I didn't get there fast enough to catch her. And she wound up face planting, and I think she had glasses, and I think she chipped a tooth and got it. So after that, I felt really, and I almost got there, but I didn't quite, and she was fine. Luckily she was totally fine. But ever since that face plant, I've no longer have that pleasure of my patients passing out, because I mean, she could have gotten really hurt. Luckily, she didn't get that hurt. One of my favorite pass out stories is, I still remember back when I was a resident, in a similar kind of setting, we were operating at Kings County Hospital in Brooklyn, and we were doing, I don't remember exactly what surgery it was, but it was a big open surgery. We had this medical student there with us, and we're holding retractors so we could see and work on what's going on and everything. And I think it was a mid-level resident. So I wasn't even like the key guy in the surgery, but I was kind of the one helping, be the orchestrator a little bit. Since I was mid-level, I was high enough to kind of coordinate, but low enough not to be the main one doing the surgery. And I had given this retractor to the student. and he's holding on, for dear life to open up the abdomen so he could see and work. And I remember all of a sudden he goes, "Dr. Cohen?" And it was like in slow motion the way he said it. And he's looking at me, but he's like looking through me. And he goes, "I'm not feeling very well." And he's holding this retractor, and all of a sudden he starts to go backwards with the retractor, and his weight started taking the patient with him off the table because he was leaning back and he wouldn't let go of it. So the attending surgeon like threw the guy's hand up so it wouldn't take the patient anymore. Luckily, someone got behind him, caught the student. But that was a fun one. That was kind of a fun one, watching him almost take the patient
Luckily, he
down.
didn't like stab another surgeon with a retractor. Nobody else got hurt.
Luckily, nobody else got hurt. But it's so common. Our students, our pre-med students especially, are really nervous about, am I going to pass out? And it's in every TV show. And the reality is, it is incredibly common, not just with newbies, like even someone, experienced, if you're not feeling well that day, if you're maybe a little sick, if you didn't eat, it's a weird situation sometimes, and you're gowned up, and sometimes it's hot in there. So it happens to everybody. So medical students, pre-med students, don't be discouraged. Don't be afraid if you're like, I'm not good with the stuff I get. It happens to everybody. Don't worry about it. If it's something you want to do, don't let it discourage you. That's my advice about that.
It's really interesting that it happens to a lot of people, but I feel like it's never happened to you. True or false?
I've never actually passed out in surgery, but I've had experiences where I've been like, I got to go and sit down for a minute because I felt like weird. And even in like luckily not recently, but even as like a mid-level person, I don't remember that much anymore, but I remember having to step out and kind of sit down. And I've even had like partners have to do it, in the middle of surgery. I think the one thing that happens when you're seasoned is you realize it before, because I think what happens with a lot of the students is they start trying to talk themselves through it, and then they get all worked up, and rather than go and sit down. So I think knowing how common it is and what it is, I think as a senior surgeon, you're more inclined to be like, whoa, I got to go sit down before I get there. So I think that happens sometimes, especially like if you're under the weather a little bit.
Okay, that makes sense. But you watching that clip, like you didn't cringe. That doesn't do anything for you. Like it's hard for me to watch that clip.
No, that was pretty gross. That was a good gross anatomy thing. And that's pretty interesting about the Pitt. They really showed, they didn't hold anything back in terms of what they were showing. We'll talk about more episodes. I mean, there's that scene with the birth, and she's in her vagina. They're showing his hands in her vagina, which is...
That is not one of the clips I decided to show because
right.
I think everyone remembers it.
Yeah, but I'm not sure. I don't think a show has done that. A medical show has gone gross like that, right? Or that gross, maybe. They've done shocking things, but they've really, they really, in fact, I think they probably stole from Gross Anatomy. Maybe we should sue them because they're trying to be gross or something like that.
I think it's working. Everybody's talking about the show. But so going back to the original question, did the surgeon seem legit? Did she seem to take command of what do you think?
Yeah, I think it depends on the place and depends on the culture. And there definitely are some places where the surgeon, is the typical surgeon, and depending on the illness or the disease or the trauma, it's kind of known. If it's a trauma related thing, the surgeon is supposed to take over. Back in my day when I was training in the emergency room and residency, emergency medicine was a much newer specialty, and the emergency medicine doctors were trying to kind of stake their claim and prove their worthiness. So I think there were way more clashes back in my day between the emergency medicine doctors and the surgeons kind of saying, hey, this is my turf or my turf, because at least where I trained, the whole and back in my day, emergency medicine was really new, and it was a brand new residency when I was there. So there definitely, were some issues sometimes about like who's in control of this. But now it's been around for so long, I think there are much more established protocols, like who's going to be in charge for what thing. But definitely, they did a good job of demonstrating the surgeon's swagger, especially the trauma surgeon's swagger. There definitely is that, at least, in my mind.
Okay. Interesting. Yeah, because I don't know if they're consulting older doctors, but I feel like in the Pitt and the ER they do like butt heads a lot, even though I feel like there are protocols. I don't
Yeah.
know. We'll get to that later.
Yeah, I think the butting head seems more like it's fun banter a little bit. Like it almost feels like it's like foreplay more like kind of just having fun, less than antagonistic. Whereas I still remember one time as the emergency. I was the trauma mid-level resident, and I think I've even talked about the story where there was a patient who came in with his throat slashed wide open, and we don't know why. But amazingly, he wasn't bleeding. It was like a perfect slash right down to his carotid artery and jugular vein, which were visible but not slashed. So the only thing slashed was his trachea, his airways, and it was wide open. It was as if someone sliced through his trachea and you could see the top half and the bottom half. The emergency, and I was the mid-level resident, and there was an emergency medicine attending, so the equivalent of Dr. Roddy, right? What's his name? Robbie, Dr. Robbie, the equivalent of Dr. Robbie. And that doctor was in charge because he was senior to me, even though I was the surgeon. And he's like, belting out instructions to secure the patient's airway, to make sure that the patient's breathing was safe. And he's belting out all these instructions and telling everybody to go get this, go get that. And what I did, typical surgeon thing, is I just took the breathing tube myself. And while everybody's barking orders, getting ready, getting prepared, the windpipe was just sitting wide open. So I just put the breathing tube in. And initially he turned to me to get all angry. And then he realized I did the right thing, by securing the air really quickly. And we had a good relationship. So he was pissed initially, but then he was like, all right, Cohen, you did okay, and
Yeah.
that was that.
Okay. All right. So that was one of my questions. But there's a clip later that even gets into that more. All right. So that's episode 1. And then, in episode 1, she gets a nickname, Crash, after that. So is that a nickname you've heard residents called, or any good nicknames for us?
No. Never in real life have I been involved in my medical days. Definitely when I was not a nice young teenager and stuff. But once I was already in college and out of college, we never did that.
Okay.
Yeah. And that's, I don't know if we're going to talk about it a little bit more, but yeah, no, I never saw it. I mean, maybe it does, but I never saw anything like that.
Okay, yeah, because she's not the only one that has a nickname, so that's interesting.
Yeah.
I was wondering if that was common, but that's not something.
It definitely wouldn't fly today in today's kinder, gentler world. I don't think, I think that person who did that would be called out, to the well-being committee and in trouble, right? Like, you can't do that today,
Okay.
unless it's a cute or a fun, or a rewarded nickname. But you can't. I don't think you could do that today and not be in trouble.
Right. Okay.
Yeah.
All right. So in episode 2,
maybe in Pennsylvania, but certainly not in Los Angeles, and I doubt in New York.
You're right. There could be different rules in Pittsburgh, I guess.
Yeah.
Not sure. All right, episode 2, there's a lot about a DNR because an older patient, he's brought in from, a home care place. His children come, his older adult children come, and Dr. Robbie's really frank with them. He's basically like, he has a DNR, there's nothing else we can do. But then the kids say, which I've never heard of before, that they have durable power of attorney for healthcare. So then they decide that they do want to intubate, even though Dr. Robbie's like, he will suffer and the outcome will probably be the same. He's gonna die because he has pneumonia and he can't get better. But they decide to do it anyways, even though he has a DNR. So my question is, and the siblings are kind of like fighting over what to do. Do you see a lot of that? Because you treat some patients, end of life, I guess. Is what you call it.
Did we want to watch that clip or not necessarily?
I don't have a clip for every one of them.
Good, because I don't want to watch that clip.
Yeah, no, it's a long. It's like it goes on to multiple episodes.
Yeah,
so that's kind of it.
There's definitely always family dynamic, and it's not super common, that one family member wants something, another family member wants another thing, and the family doesn't necessarily agree with the parent or the relative who's ill. That definitely happens. Usually we get social work involved right away, and all of the support staff involved right away. But I don't know for sure if a patient has a DNR, if they're quote competent. I don't know these days. Luckily I haven't had to deal with that stuff in a long time. End of life patient
Mm.
care. My practice has changed a lot, but I don't know if a patient is considered competent when they lose consciousness and they have a DNR. I don't know if a family member even if they have durable power of attorney, I don't know if they're able to revoke that DNR. I don't
Mm.
know what that policy is. And that's an interesting, maybe we could have a viewer or
Yeah.
let us know what the policy is. But um, I don't know if they could say no. I know Dad had a DNR, but we're not saying okay. It's one thing if it's not on paper, if one sibling said Dad always said I want to be DNR, and the other sibling said no, I didn't know that, and it's not written anywhere, and there's no paper of saying DNR. Then it's an issue. But for sure, then it's definitely
Mhm.
could be an issue. But and the patient could say, have a paper that says I'm DNR, and then when they're sick, say, no, I changed my mind, I take it back, I don't want to be DNR. You have to listen to the patient. But I'm not sure about what truly happens.
We'll say that there is no DNR and there's no kids. Does what a doctor just decide to resuscitate, or how does that work?
No, so a little bit is the decision is what futility. Is it futile? Is the patient not going to really make a recovery? Is what was you kind of take everything into account. If the patient was in a vegetative state with no family and no for whatever reason and no quality of life and comes in and they need to be resuscitated or intubated, in that case, an attending may say, "Why are we doing this?" and may elect to not proceed. So there's that. It's not clear cut. It's not black and white. Certainly, if there's a chance of making a full recovery. And there's nothing in there, no matter what their age is. If they were 100-year-old walking around 1 minute and for whatever reason they just stop breathing, then it should
Right.
be full resuscitation,
Okay.
unless there's wishes that the patient doesn't want it. But if there's a question of brain death or this or that, that's a different story. It's
Right.
interesting, it does have to do a little bit with someone who's young, versus someone who's old, and overall health conditions.
No, it does seem very complicated. So, all right. Thanks for answering that question.
Yeah. Although
Um,
I will tell you, it is a little, and I don't know if we're going to talk about it in other questions of yours. The having the I've never seen and the family and friends have that much access to being in the emergency room when all this stuff is happening. That
but that's a really good question that I didn't even write down. I mean,
okay,
I got used to it after a while. So
yeah,
that's not common.
they never have family there when intubation is going on, when any of that. It's always you get out of here. We're going to do our emergency procedure, and then you could come in, unless there's no time and they happen to be there. But otherwise, the amount of access that family and friends had in the Pitt emergency room is insane and is just fantasy. Unless they're somewhere in the world is just nuts. I can't imagine that for so many reasons. It would just make things chaotic and nuts. But the
Mhm.
amount of just family being in there for all these procedures is totally ridiculous.
That kind of reminded me of ER too, where there's just all of a sudden there'd be like a kid watching this horrible thing and be like, "How did they get in there?" But I
Yeah,
mean, it's like from one of the writers of ER, so I guess
yeah,
it feels more like a play that way, I guess, because everyone, the characters are all on stage.
right. Oh, that's nice. I like that. It's a play.
But you're right, it is kind of crazy that
Yeah,
everyone's in one room, one
yeah,
tiny room.
yeah.
For episode 3, we're moving on to episode 3. I do have a clip. It starts with chest compressions because the R1 is losing his first patient and he just can't accept it. And
Yeah.
so keeps doing chest compressions. But we have a video.
Oh, shit. What? I think I just broke some ribs.
Means you're doing it right. Third amp of Epi's on board.
Oh, come on.
Call me if there's a resurrection.
So that's the chest compression scene. How'd you feel about it? How'd the R1?
You know, that's always, as a doctor watching chest compressions, in TV and movies, it's always interesting to watch how accurate, how well they seem to be doing it. Some of it, the motions are pretty good, in terms of being real. The only thing that's weird is that, when you're doing chest compressions, ideally you want to be able to put your whole weight of your upper body into that chest compression. And what's weird is how high up the patient's bed was. So, he's like way high up. He can't get his whole body down. So like the bed should have been much lower so that he could, I thought it would have been much more realistic, but I thought he did a decent job, the acting and the direction of it, other than the fact that you can't do a good chest compression from above. It's about getting your whole body weight so you're not exhausted doing the chest compression. The other thing about chest compression is often, they have one or two people taking turns and it's not just one person, so you're not exhausted the whole time. But it is common to break ribs, especially in the elderly during chest compressions. And that's, and I don't know if it means that's what his line that you're doing it right, but I'm sure that's been said. And to some degree, it's really common, especially in the elderly, to break ribs because you're, the heat of the moment, you're working hard, you're doing your chest compressions. So that's definitely not uncommon, is broken ribs during chest compressions.
Have you ever witnessed like a resurrection? Like the doctor, I mean, he said it kind of, I think, jokingly, but
Yeah.
part of me thought maybe he's seen like a resurrection before. He didn't tell him to stop.
Yeah, no, he let him do it because he felt bad and wanted to let him kind of, get his first thing going. So, no, we've revived. I've seen people get revived with CPR, with chest compressions. Usually it's, a quick, something is reversible and happens, or for sure. I mean, it definitely happens. Not that often after doing it for a long time, especially in someone who's elderly. But it's not uncommon. Sometimes you get the rhythm back for a while, then you lose it again, you get it back for a minute, you get a pulse. In fact, one of my, and I think I've talked about it in different places, one of my favorite experiences as a surgery resident, again, doing trauma, was some patient came in, brought in by the ambulance, stabbed in the chest, a single stab wound in the chest. And I think they were alive still in the ambulance and lost their vitals, kind of died in the ambulance right as they were getting to the hospital. And there are some indications, and it's even mentioned in a later episode, there are some indications to open up someone's chest and actually massage the heart manually and try to fix everything. So, and that's one of the indications, is someone loses their vitals, has vitals and then loses it. And that's one of the indications to what we say crack a chest, to open up someone's chest. And so we did that. This patient came in, full trauma team going. I opened, as the mid-level resident, the attending took me through slicing open the patient's ribs, spreading open their ribs. I got to there, I saw the injury there may have been an injury in the lung and the heart. I quickly sutured those up, then took the heart out of the pericardium, the sac, sutured up the hole in the heart, as everybody else is working, giving blood, doing all this stuff. But I'm just focused on that. And I was squeezing the heart, to try to do CPR, was me squeezing the heart in my hand. And then we would shock the heart with these little internal paddles. And we would keep getting the heart. We worked for a while in the ER, and we actually got the patient back a few times, lost him, got him back a few times, got him back long enough to actually wheel him up to the operating room with me, standing on the gurney, kind of with my hand in his chest, still squeezing it. Worked for a while, got it back, but ultimately lost the patient. But that could have been one of those rare experiences where you actually save a patient, and
That would, yeah. In a TV episode, I'd like to see that patient survive. That's a
yeah.
good,
And I did not have a gown. It was back in the day when everyone was gowned. Although I guess maybe, but for whatever reason, I wasn't gowned up. I was just in scrubs, and I came out of there a bloody mess. But boy, did I feel like a surgeon. Like that was kind of like, I still remember it as like one of those, rites of passage when I remember. And I was a third year mid-level resident. Yeah. And I was like, now I'm a surgeon. It was a cool experience. It would have been cooler had I been able to save the guy, but.
Well, I feel like nothing would upset you after that. I mean, that's like, if you can hold someone's heart in your hand, I feel like you can do anything.
Maybe. I don't know.
Maybe. All right, episode 4. We also have a clip, but there's a psychotic patient, and a charge nurse assembles a team to give him meds. And I'm just wondering I feel like you might have a problem with this. Let's watch the clip.
Okay.
Psych wanted to transition him to oral meds. There's an order for an olanzapine tablet at 9:30 a.m.
Yeah, that's on us. I've been with criticals all morning. He needs to go upstairs to behavioral health. We're too busy down here to dispense psych meds on the schedule.
Understood. What options are we left with?
Either we let him tire himself out or we go in and stick him.
I'm worried he's gonna hurt himself.
These are partial soft restraints. What we really need is a padding and blow dart. Who is you, your warden?
I need an order for an agitated psych patient, been here for days, methamphetamine induced psychosis.
The Kraken?
Really should call him. I'm about to be 52.
No, that would take way too long. Type the staff. QTC?
Normal?
5 of bedazolam, 5 of Haldol, and Mr.
Kokosia.
You're joking.
No.
Mr. Kokosia will be out like a light under a minute.
Okay, we have a quorum. That's finally here?
Yep. Guys got some energy.
Let's do this. Donahue right leg, Larry left leg, Kim right arm, I pull left arm, Perla takes the head, and our young man here will inject. Clear?
Yeah.
Pull socks?
Right here.
Good luck.
I am injection to the mid-anterior left side. Everybody ready?
Yo, Whitaker, you play any ball?
Oh, football?
No, dodgeball. Of course football.
Yeah, some pee-wee. I was actually a pretty good kicker.
Not helpful. Look, Larry and I are gonna block for you. Come in right behind us. When we split and go for his legs, you go right up the middle. End zone, baby.
Yeah, got it.
Okay. You ready? 1, 2, 3. Okay, Mr. Kokosia, we're here to help you. We're here to help you. Oh, God. What do
Congrats, kid. You just earned your yellow wings.
Okay, bedazolam will take him down in a minute. We'll monitor him for 20. After that, the Haldol will kick 10.
Yeah, he's settling down now.
Do I really need to be here for 20 minutes?
Why? Got a date?
I mean, I'm covered.
I'm kidding. Thanks for your help. Gotta get cleaned up.
Hey, thanks everyone. Good work. I know I don't need to say it, but let's try to stay on top of Mr. Kokosia.
That was a lot with a psychotic patient. A lot of people to talk to before it got to that point where they just went in as a team and stabbed them.
Yeah, that's definitely a fun episode. My guess is they have all these consultants, so my guess is that's probably happened somewhere with some doctors who have given the writers ideas in terms of script. So luckily, I've never had to do that. I'm sure I treated psych patients. Maybe I put it out of my mind having to deal with that stuff. Luckily, I've never had to do that. I don't think I've gotten urinated on either like that. Maybe by my kids when they were babies. But other than that, have not had that happen to me. But I'm sure stuff like that does happen to some degree. I don't know why he's not already like in more of a restraint. But I don't know. Luckily, I haven't really had to deal with that kind of stuff in a really long time. I mean, medical school would have been if and when I had to deal with that. So I do love that charge nurse. I think she's great.
Yeah, she is. She's one of my favorite characters.
Me too. She's one of my favorite characters. She reminds me of charge nurses that I've been dealt with. She's written perfectly and I think she's acted perfectly and her sarcasm, her toughness, I think is right on. And in fact, I think they could have even made her more tough. and it would have
Mhm.
been believable, a little harder on the outside, but still soft on the inside. I had many charge nurses like that back when I was a med student in the surgical intensive care unit. We had this really tough, kind of mean charge nurse. I wish I remembered her name. It may come back to me. And she would be tough on the students. But if you earned her respect, and if you earned her, if you proved yourself, she would love you and take care of you. And it was hard to. Her name is on the tip of my tongue. She was scary, but once you earned her respect, she was still scary, but she was great. And you knew Bernadette. I think her name was Bernadette, and I may have even had her write me a letter of recommendation for residency or something like that, because I eventually bonded with her, and just by working hard. Bernadette. She was good.
Bernadette's
Kings County Hospital.
that's a great character name and a good real name, strong name. So maybe that situation has happened before, because like you're saying, if a charge nurse has everyone's respect, I mean, they're going to go in there with her. They're going to do what she says.
Probably, yeah. Because at the end of the day, the charge nurse is the boss. Not Dr. Robbie. The charge nurse is the boss.
Okay, so they get that right. That is interesting. That's the first time I've really felt like I've seen a charge nurse. Like, I don't think they had that character in the ER, really.
I don't know. Wasn't the charge nurse in ER Juliana Margulies?
Oh, was it? She was the head nurse. So I guess that's the same. Yeah,
Yeah,
maybe.
yeah. But she
I guess
was
it
she was
just
not
worked.
as she was a little softer, not and younger, So I think
Yeah,
yeah,
it came across different, but
yeah.
I enjoy the charge nurse. So you haven't had to deal with anyone in restraints. I feel like you worked in a prison for a while. Didn't you treat people in a prison? And
Yeah,
you
so
psychotic
Kings
break?
County, Kings County was I guess like the Pitt. It was like old time county hospital back in the day. I was there in the pretty much the entire 90s. I was there in the entire 90s. I was there from 91 to 2000. I was at Kings County Hospital. I spent a lot of time at King because I did med school and residency there. And amazingly, they had a prison ward. We had a prison ward,
Mhm.
a full lockdown prison ward where you actually had to go. You went through one door, it would close. You went through another door, it would close. And there were prisoners on this open ward. They didn't have private rooms. Just a whole bunch of patients laying there, bed. Kind of like like a barracks. Um, Interestingly, at least they were all pretty respectful guys, and they were all, I think they were happy to be there and happy to have someone taking care of them. It was scary. There were always security guards and stuff there. And, luckily I never saw anything happen, but it was definitely always an interesting thing to have to go to the prison ward. It was a whole separate building. It was really an interesting experience.
Okay. Yeah, I was wondering if you had any like psychotic breaks like in that time that you remember that were like that, but no. That's
But
good.
we actually, in addition to the prison ward, we had a whole psych building called the G building. Now that you mention it, one whole building was this psychiatry building where the patients were locked down there, and it was the same kind of thing. And it was far away. You had to schlep over to the G building. And I still remember as a second year medical student, we weren't yet doing our clinicals, but we had like this intro to clinical medicine where we as a group would kind of now and then get to experience different rotations. So I remember on our psych rotation, we had, I think, an inpatient who had borderline narcissistic personality disorder, but it was a very well-to-do woman, and our preceptor assigned one of the students to interview this woman. And this woman was brilliant. I think she had been a lawyer. She was smart as a tack, but she was borderline and a little psychotic. And I remember it was so cringeworthy because the patient wound up kind of taking over the interview and the student didn't know how to handle it. And for whatever reason, the attending psychiatrist didn't intervene, and the
Oh.
psychiatrist allowed, we were sitting at a round table at an oval table. The psychiatrist allowed this patient to humiliate this medical student. I still remember it. I still remember how cringy the student would try asking questions, and this patient was so smart and attuned that she picked up on all the insecurities of this student and called her out on all of it. And it was definitely not same kind of experience, but for whatever reason, it just popped back in my mind how God, I felt so bad for that student. It was humiliating, and there were all of us sitting around. It was humiliating.
Yes, I'm sure that was cringeworthy, but when you were telling that story, I was like, I feel like you just wrote a great episode of television. That's an episode right there.
Yeah, it was like Anthony Hopkins, kind of
Mm-hmm.
reversing the interview a little bit.
Very interesting. All right.
Yeah.
All right, so we'll move on to episode 5.
How many episodes are there total in the Pit? 12?
15.
Wow, 15. Okay.
Yeah. All right, so Dr. Robbie criticizes an R3, Dr. Mohan, for taking too long, and her nickname by everyone is Slow Mo, which again, you already talked about the nickname thing. That's not really something, that's not nice, obviously. They wouldn't get away with it today.
There's no way today they would get away with it. Certainly not in LA. Maybe there, I don't know, but the culture would that doctor would be in so much trouble for calling someone that. Harassment, bullying, no way would it be tolerated.
Okay, well, that's her nickname, but then so he criticizes her because basically he has to, they have to get through patients faster. So my question for you is, working with residents, is that something common that you have to tell them? Because obviously they want to take their time, they want to be as perfect as possible, but you have a lot of patients to see.
Yeah. No, it's definitely a challenge. Oddly, I tend to prefer slow and steady, with certain things. Like in surgery, I do not like surgeons who go fast. I do not like my residents who go fast. I think it could cause sloppiness and could potentially cause errors. And so I actually, I could be criticized. One thing is, while I used to be slow a little bit, but now I think if you go along the right steps, even if you're kind of not hurrying, it moves along. Mm-hmm. But certain times, I definitely will tell a resident. I try not to because sometimes telling them to hurry makes them even more self-conscious and slows them down more and maybe might make them nervous or make them shake. I've seen that all too often. Like one of my partners will sometimes say to the residents, hurry, and it doesn't do any good. It doesn't necessarily do any good. But I do tell sometimes. The way I'll say it is, you have to think about conservation of movements, I'll say, rather than, do something twice. I'll say, be more definitive, respecting the tissue, picking it up a certain way, doing that kind of thing. But yeah, it is. Sometimes our residents don't show up on a surgery and it'll just be me either by myself or me and a partner on a harder case. And I hate to say, as much as it's nice having the residents and teaching, it definitely is faster when we don't have to teach the residents and things move along faster. But at a teaching institution, you got to do that.
That's true. And Noah Wiley I feel like he does reference that. He's like, this is a teaching hospital. But then, so that should make up for some of the time. Obviously they got to learn. It's going to take longer.
But he seems, he's like a great teacher, in the show. And he really is. Mm-hmm. And for the most part.
Did you know Noah Wiley is a writer? I noticed that when I was rewatching. He wrote 2 episodes of this.
Yeah, I saw that. I think because he learned how about all the shows on. How many seasons of ER was he on?
I thought he was on all 15, but I think he took a break maybe for a year and a half or something.
Right. Yeah. So he's probably, probably a good doctor at this point too.
I'm sure he gets asked doctor questions all the time. It's probably
I bet.
But I think this time it'll win him an Emmy, so we'll see.
100%. He's really great in that. And I think that charge nurse should get an Emmy too.
I could see that.
Yeah.
I think they'll both definitely be nominated. So now we're moving on to episode 6. This is a good one. A resident fainting with a tool. I was like, oh, good thing it didn't go into someone's foot. But this resident just dropped it perfectly.
Yeah.
What are your thoughts?
Yeah, It was a funny scene. I thought I thought it was I thought it was great in terms of the comedic element of it. Um, I would have liked to have seen her nervous. Like, was she nervous or just clumsy? Because her hand doing the chest tube, making the incision was totally smooth. Like there was no shaking or anything. So, so she was just being clumsy, which I don't understand. Like, did she just make a mistake? So in my mind, I was like, is she just a butterfinger? Or so that was the only thing in my mind. Like, because she did not seem nervous at all until after it went in her foot. Then she was nervous that she screwed up. So, but yeah, it could fall out of your hands, I suppose, anyway. But it reminded me of one of the surgeons who I first trained under in my surgical oncology, told me the story how he once, when years ago, even before I was training with him in cancer surgery, he was doing a surgery with a resident, and the resident accidentally cut his hand, and they scrubbed out, and he actually made the resident who cut his hand suture him back up. And I love that. I love that story. He made the resident suture him back up, and I couldn't believe it. I wonder if that's where they found that thing. But I just thought that was really cool that he made the resident suture him. He's like, okay, you cut me, you got to fix me, and I don't think he was even pissed. I think he.
Okay, so that is. I feel like that has happened before, and you just proved it.
Yeah, no, those. I don't know about a knife in the foot, but I'm sure. I'm sure if they came up with it, it's happened.
Well, what's interesting is that R1, Dr. Santos, does offer to like stitch her up, and she's like, no, she wants to do it herself. She's
right.
like the opposite. She's like, don't touch me.
Right, exactly. But I like the fact how cool and calm she was. It was interesting.
Yeah, she was. But you're right. I didn't think about that because the Dr. Santos character, she is very confident. So maybe it did just slip. Like she's not nervous. Like that's not her character.
Yeah, it must have just fallen out of her hands.
Yeah.
Are we gonna talk about Dr. Santos anymore in these episodes, or not necessarily?
We can get into it. I didn't really have any specific questions. Did you like that character?
No. Did you?
Yeah, she's a lot. I mean, she gets a little bit softer at the end, or they give her a little backstory where you're like, feel sorry for her. I don't know.
Yeah.
It doesn't work for you?
No, she's someone I would hate to have to ever work with because she's not a team player. She's a bully, that she's giving nicknames out to people. I doubt, she would be one of those people who, if given a little bit of power, could be very malignant, and hurt other people, especially seeing how she is as a junior person. I don't, I would never want to work with her.
That's interesting.
And I would be very worried. Like I would be like, God forbid I accidentally call someone a nickname or something like that. She seems like the first person that would take me down, if she had anything against me. Like I hate that character. I mean, I'm sure there are people like that, but
no, that is exactly how I felt. So that's interesting from your doctor perspective. You felt the same way. I wouldn't, trust her at all.
No. Danger, trouble, terrible.
Yeah. All right. Well, we definitely agree on that.
Yeah.
All right. Let's get to episode 7, and then we'll call this a part 1 of of Dissecting the Pit. All right. So there's no clip for this one. But so Mel King, she was one of my favorite characters too. I think she just called herself Dr. Mel. But I looked it up because I wasn't sure. She's a neurodivergent resident who exhibits characteristics of autism.
Okay.
I just thought she was like a happy, hopeful doctor mainly, And I mean, like, I thought her character was interesting. But she works with a patient comes in who is autistic, and she knows how to work with him specifically. Another one of the doctors is really impressed. He's like, how did you know to do that? And there's obvious reasons why she knew how to do that. But my question is, do you guys have, now that so many people seem like they're on the spectrum, or the spectrum's a lot wider now, do you guys have training for that? How does that work?
You mean, do we have training
as doctors to, like, if someone comes in and they're, autistic, or they, you have to speak to them a certain way, like she's speaking to this patient about his leg, and no one else seems able to do that.
Yeah, as far as I know, I don't think there's any specific training in dealing with people with different personalities and things like that. And I think most of the time it just has to do with experience and empathy and a little bit of luck. I've definitely had plenty of patients that I've taken care of on the spectrum or disabled, developmentally disabled in different regards. And I think the goal with anybody is to try to figure out a way to connect and whatever it is and slow down and listen, which is what she said. She said, I listened to him, I think, right? Isn't that what
Right,
she,
you're right.
yeah. And I think that's important. I think listening as a doctor, but as a person, I mean, I think that's a great Mentoring Monday. And I've talked about it before is listening is so dang important.
Right. And I guess it's a you learn by doing type of thing. Because as you said, you've had a lot of patients that come in that are autistic. So I guess you just
Yeah.
learn by doing.
Yeah. A little bit.
Okay. Do you want to? All right. We can stop now if you
Yeah.
want.
The interesting thing is she's not the first, it made me think of what's that TV show? I think we even watched it. Was it No, not The Resident. The one about the doctor who's on the spectrum. We talked about that show.
Yeah, it was The Good Doctor. You're right.
The
There's a
Good
whole
Doctor,
series about
yeah.
it.
And I think we even may have done an episode reviewing
Yeah,
that
we
show.
watched like the first one. That was a long time ago. I kind of forgot about that show, but it aired for a while, so it must have been a successful.
People liked it, and the entire show was about a doctor on the spectrum.
You're right.
Yeah, which is interesting. Yeah.
Yeah. I mean, that one, yeah, I'm trying to remember. I don't feel like he was like Dr. Mel, but maybe he was.
He was a little bit, although even more detached. Like Mel is not detached. Dr.
Mhm.
Mel, demonstrates emotions much more. But the good doctor was completely detached and couldn't necessarily connect. But yeah, the Dr. Mel character is a sweet character. Just
Mhm.
an interesting fact, and I think we've talked about it, is that our old friend Mariano, who I love, shout out to you, Mariano, who was doing our social media at one point. He auditioned for this show, and I remember way before the show came out, I remember him practicing his lines, and I tried to go over them with him. I don't think I helped him, unfortunately. I feel so bad. And I think it was I'm not sure which character it was. It was either the main resident guy, what's his name?
The main resident, I think there's Dr. Whitaker, the white guy, the white kid.
Not the student, the resident who gets booted out later on.
Oh, yeah. What is his name?
It was-
Dr. Langdon.
It was either, I don't know if he was reading for Mateo, who's the nurse, who's the cute nurse, or Dr. Langdon. It was one of those two roles that he was reading for. And he would have been great. And I mean, both of those actors are doing a great job and are
Yeah.
great. It would have been so cool had Mariano gotten that. I think the show, as good as it is, would have even been better.
Right. No, I agree with you. Yeah, Dr. Langdon is a interesting character. I mean,
Yeah.
we
And
haven't gotten into
interestingly,
that
some of the lines that we read were in the show, and I was like, "Oh, I remember rehearsing that with Mariano, which was kind of fun."
yet. Aw, that's
But
so
obviously, I didn't direct him properly.
Well, don't you also know someone who makes appearances in the show?
Yeah,
Were they in those clips?
yeah, exactly. And she's even in Ambar is even in some of those clips. And as the show progresses, she starts having. In the beginning, she didn't have any speaking parts, but as the show went on, she had a larger and larger part. So it's kind of exciting to watch too. And I recently had a coffee with her the other day, so it was great to kind of catch up and hear about the show.
Is she already filming season 2?
They haven't started filming it yet. No, I think they're still trying to figure out season 2. At least that's what she told me. So who knows? I told them I'm available.
Nice. Makes sense.
There you go.
Well, I hope it happens. Well, thank you, Dr. Cohen, for answering all my questions.
Thank you, Lauren Taylor. And Noah Wiley, whenever I know you've been trying to get on our show, but if you really want to, just reach out and maybe, we'll try to make some time to get you on the show.
I know. I'm gonna start wearing like a Noah Wiley shirt or some kind of gear. I'm a super fan, so that would be amazing.
He's great. My only thing about Noah Wiley is from ER, where has he been between ER and the Pitt? Has he done stuff?
Yeah, he has done. He's done like TNT shows, stuff that wasn't gonna win him an Emmy, but he's always good.
Right. Has he been in movies? Have you seen him in a movie?
I've never seen him in a movie, so I was curious about that. If that's just not the way he wanted to go, or why?
Yeah, it's interesting. He like George Clooney clearly, went one route, but Noah Wyle, I'm trying to remember. I mean, I'm sure if we IMDb him, we'll see he's been in stuff, but it's really ER and now The Pit.
Maybe it's like TV because he just has a certain schedule that he sticks to and he had kids. I don't know. That's why we need him on the show to answer these questions. Like I know Eric LaSalle, like he wanted to be a director, and then Goose also wanted to be a director. So I know that's the way they went, but I don't know about him. He's obviously a writer. I didn't know that.
Yeah. Interesting.
All right, Noah.
And there you go. Well, thanks for joining us, everybody. Thanks for joining us on Gross Anatomy. We love having you. Give us feedback. Give us questions. Talk to us. If you have any ideas of guests that you want on our show, reach out to us or contact us.
Yeah, please let us know.
Hey, everyone. Thanks for listening. Tune in next time when Lauren and I will dissect the second half of The Pit.